everyone, welcome back to my channel. My name is Susan, and if you're new here, welcome. So today I am going to do a requested video about the differences between ICU nursing in the UK versus ICU nursing in the USA. So let's begin. I have some points written down, so you'll see me looking down to make sure I don't miss any points while I discuss the differences. So in the UK, your patient workload is 1. So 1:1, one ICU nurse to one ICU patient. Occasionally, very rarely, you get 2 patients as an ICU nurse in the UK. Whereas in the USA, your workload is 2:1. So you get 2 ICU patients to 1 nurse. So 1 ICU nurse for 2 ICU patients. So which means everything is double. Double documentation, double medication, double nursing care, double everything. Yeah. Point 2 is that nurses in the UK are trained to deal with ventilators. They set up ventilators, they do ABGs. They don't need to be told when to do an ABG, just based on the patient condition. And they also adjust ventilator settings, and they report the changes to the ICU doctors, who then oversee the general care of the patient. But in the USA, nurses are not trained in the ICU to deal with ventilators. There are respiratory therapists that are trained to deal with respiratory issues, and they do ABGs, and they do adjustments with the ventilator settings according to the ABG and the presentation of the patient. Yeah. Then the third difference I remember is that in the UK, you have organized documentation, but it's not cumbersome, it's not too much. And over here in the USA, you have detailed documentation, which is a bit too much. Some things are redundant because things are repeated, and then you got 2 patients. So this makes documentation very time consuming. In the UK, ICU patients are repositioned every 4 hourly. In the USA, ICU patients are repositioned every 2 hourly, and you got 2 patients, remember that. So it's like almost hourly that you're doing repositioning. Okay. In the UK, you have 1 CRRT, and that's it. You're not going to get any other additional patient. Once you have 1 patient on CRRT, you are going to get 1, and then other people might double. You're not going to be doubling if you've got a CRT patient on a CRT. In the USA ICU, sometimes you get 2 patients on the CRRT. It can get really busy. In the UK, relatives visit at visiting times, and around 7 o'clock they go home, except if the patient is deteriorating and they are allowed to stay overnight or stay and come and go as they wish because the loved one is deteriorating. But in the USA, there is no such thing as visiting times. Relatives visit at any time they like, and they could stay at the bedside for days. So yeah, there is no visiting times. Here in the USA, relatives come in at any time they want. In the USA, they call brand names. So the medications, they use the brand names, whereas in the UK, we use generic names. Midazolam is midazolam. Lorazepam is lorazepam. In the USA, they've got different names. Midazolam is Versed, and so on. They've got different names they call them. So it could be confusing. But in the NCLEX exam, they use generic names, so I don't really get it. Why are they using brand names? ICU nursing in the UK is like nurse-led, with the permission of the doctors to do certain things. Whereas in the USA, ICU is doctor-led. ICU care is doctor-led. So I would say in the ICU, UK ICU, nurses have more autonomy than the nurses in the ICUs in here over here in the USA. Let me say that again. So autonomy-wise, UK ICU nurses have more autonomy than USA ICU nurses, because in the USA it's doctor-led, ICU care is doctor-led, whereas in the UK it's nurse-led with the permission of the doctors to do certain things. In the UK, patients are managed mainly by the ICU doctor, although there might be other specialities involved, other doctors from different specialities involved in the patient's care. In the UK, they liaise with the ICU doctor, who then tells the nurse what to do, what they need, and all that stuff. Whereas in the USA, the nurse has to do consult not just the ICU doctor, but other doctors involved in an ICU patient care. For instance, if the patient is under the nephrologist, you do not ask your ICU doctors questions that relate to nephrology. You have to deal with the nephrologist, consult with the nephrologist, and if the nephrologist is on call or off work, you need to go through a paging system, and then after going through that paging system, somebody will speak to you, and then the doctor will then call you back, and then you now tell them what the issue is, and they'll tell you what to do, and things like that. In the UK, if your patient is being prescribed propofol, or they are already on propofol, and the patient is kind of waking up, getting agitated, an intubated patient, you as a nurse, you use your nursing judgment and bolus propofol to keep the patient calm and safe. In the USA, you can't just bolus propofol. You need to ask the doctors, because they don't really like nurses bolusing propofol. So your patient could get agitated and you're not allowed to bolus propofol. You need to speak to the doctor first, and they'll now give you the go-ahead to bolus it, or they'll now say, no, we'll give you a different medication. So yeah, that's the difference between USA ICU nursing and UK ICU nursing. In the UK, we do A to G assessments. Or some people call it A to D, some people call it A to E, but basically it's A to G assessment in the UK, and in the USA is head to toe assessments. But not much of a difference, head to toe versus A to G. But it's basically similar, it's similar. And then in the USA, in 12.5 hours, you get a 30-minute break. In the UK, in a 12.5 hour period, you get about 2 hours break. Sometimes you get 1.5 hour break. These are some of the differences I could think about between the UK ICU nursing and the US ICU nursing. And please send more requests and I'll do more videos for you guys. Thank you guys for watching, and I'll see you again soon. Peace.